afternoon. Welcome to the session. This session is about advanced HIV disease. This is a track E session, Implementation Science. Welcome everybody. I'm very happy to be here. My name is Brenda Crabtree and I'm an ID physician and researcher at the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán, based in Mexico City. And we have 5 wonderful abstracts to be presented, all of them in 7 to 8 minutes. We will have the Q&A session at the end, so please keep your answers, your questions by the end of the session. And with that said, there's one of our presenters at the end, Dr. Landowitz, who will be presenting online because he missed his connection. So anyway, but he is presenting, so good for us. So with no further comments, I will introduce our first speaker. This is Dr. Winnie Namitaka. She's an MD and public health specialist from the Clinton Health Access Initiative in Uganda. And she will be presenting the first abstract about improving advanced HIV disease intensification among clients failing antiretroviral therapy, an implementation partner-led initiative in Uganda. Please, Winnie, come to the front.
Thank you. So I'm sharing this work on behalf of colleagues from Uganda. This work was about improving screening for advanced HIV disease, specifically amongst people living with HIV who are treatment experienced and virally unsuppressed. So why this work? One, there has been a lot of concern, especially around access to CD4 screening amongst treatment-experienced people living with HIV. There's been a number of initiatives trying to address this, but for some countries, including Uganda, this has remained unacceptably low. And this is what we found. We found that capacitating health workers and optimizing availability of AHD commodities, as well as integrating CD4 screening, especially in community services, does improve CD4 screening amongst this group of people living with HIV. Why is this important? First off, about 10% of the people living with HIV within our program are virally unsuppressed, either due to poor adherence or due to treatment failure. And this group, even though they are in care, they remain at risk of advanced HIV disease, as we shall see. And then there's another group of PLHIV, those who are returning into care. Another group that again is treatment experienced, but at risk of advanced HIV disease. And of course, as we all know here, people living with HIV, with advanced HIV disease, are at risk of death, and we are trying to reduce the number of people dying from HIV-related causes. So WHO does recommend CD4 as the hallmark of AHD identification, and this is because there are a number of people who remain asymptomatic, have no symptoms, but have very low CD4, and are therefore at risk of opportunistic infections. These tables over here, just really show the difference between advanced HIV screening amongst the new and amongst the virally unsuppressed people living with HIV who are treatment experienced. We can see here that the access to CD4 screening for those who are new ranges between 79 and 82%, but we still have very low proportion of people who are virally unsuppressed, that access CD4 screening, and this really was the gist of this work. So between October 2022 and September 2023, the Uganda Ministry of Health, with the support of the subnational, in collaboration with the subnational implementing partners and the national HDTWG, did implement a quality improvement initiative. So this work wasn't a research study, but rather a national quality improvement initiative. And the aim was to increase access to AHD screening amongst the treatment-experienced virally non-suppressed clients. These were the key interventions. There was retraining of the health workers to ensure that everyone had the right information. There was more support for data management and reporting. There was also support to improve commodity management, especially last mile distribution, as well as support from the subnational partners on the formation of facility-level AHD quality improvement teams. In addition to this, the subnational partners integrated CD4 screening in the targeted community services, DSD models that were implemented at the community level, and this was made possible through the availability of a device-free CD4 testing platform. The cascade was monitored bi-weekly to see the impact of the various AHD initiatives within the different facilities. And at the national level, the National Ministry of Health did have bi-weekly virtual meetings that were convened to share some of the experiences from the different partners and to create an environment of cross-learning across the different partners and health facilities. This is the impact. Over here, this is the quarter when the initiative happened, and we saw that there was an increase in access to CD4 within this category. To the highest was recorded was 63% in the April-June quarter. We did see a slight decline at the end, which was really as a result of some challenges in the last mile distribution of AHD commodities. The same positive impact was seen on the other tests within the AHD cascade. Specifically here we can see that there was an improvement in access to TB-LAM, which is the screening and diagnostic test for TB. We also saw increase in access to CRAB, which is a diagnostic and screening test for cryptococcal meningitis. Also, we really want to highlight that we see a proportion of about 16 to 20% of people who had CD4 less than 200 actually being positive for LAM. Same as we see about 10% of people who are treatment experienced but had CD4 less than 200 having a positive LAM. What this really emphasizes is that it's not really just the new people living with HIV that are at risk of advanced HIV disease conditions, but also those who are in care, treatment experienced, but virally unsuppressed. So it's not enough for programs to, enroll people living with HIV in care, but really to make sure that they remain virally unsuppressed to reduce the risk of AHD. So in conclusion, we see that AHD screening services amongst people living with HIV who are virally unsuppressed is critical, and it is going to continue to be critical in ensuring that we continue to reduce AIDS-related deaths. We also see that efforts, especially of integrating AHD screening services in community, different models, especially the community models, and improving last mile distribution of commodities, as well as optimizing resources, do improve CD4 testing and testing of the other conditions within the ASD cascade. And country programs really need to continue to prioritize these interventions. I would like to end by acknowledging the support of the Ministry of Health, the National HD Technical Working Group, as well as the different implementing partners who supported implementing this work, and as well as the general support of UNITAID that continues to enable access and improve safe, life-saving interventions. Thank you very much.
Thank you so much, Dr. Nabitaka. Our next presenter is Dr. Antonio Camiro. He's an ID fellow from the Institute of Cancer in Mexico City. He used to be our student in med school, so I'm super proud he's presenting right now. His work is entitled Cost Effectiveness Simulation of Implementing a Point-of-Care Test Package of Opportunistic Infections in People with Advanced HIV in Mexico City Reference Centers. Please, Camilo. Thank you.
Well, thank you, Brenda, for that lovely introduction. I'll go dive right in then. I'll skip this for time constraints, but advanced disease in Latin America still remains a big part of what we see in daily practice, and HIV-related mortality remains high and has not constantly gone down as we would expect it would be during the past decade in the region. It's expected or estimated that at least half of the deaths that occur in people with advanced disease are due to TB, histo, or crypto. And this in part is because diagnosis of these diseases remains costly and it takes a lot of time and a lot of resources. Thankfully, point-of-care packages have demonstrated feasibility as tools to expand and expedite this diagnosis. So what we're trying to do in Mexico is we're starting a prospective trial in 4 reference centers in Mexico City, in which we are going to be, well, universally screening for both TB, crypto, and histo with point-of-care tests. We haven't gotten around to doing that part, but as part of the study, we did a really big retrospective data capture, and we included all of the people that presented to care from September of 2022 to September of 2023, and we ran a simulation to see how much or how many resources we could have saved by applying these tests universally. We included a total of 324 people living with HIV in the database, and out of all of this, we found one of the 3 opportunistic infections that we talked about in 1 out of 5 of all of them. Using these standardized, more or less standardized testing algorithms, we found all of these opportunistic infections. And by doing several calculations, we estimated the range of costs that it takes for us to detect and treat any of these different infections. The most common one was TB, and then histo and crypto. Here, I'm showing you the diagram that talks about what we could have saved by using TB LAMP for TB detection. Cost reductions were assumed in the following scenarios. The first one is we could spare the use of further expert MTB tests in sputum in those individuals that we had a positive TB LAMP for, and they would just go into directed testing to detect the TB. No? And in individuals that had a negative TB LAMP, we could spare the use of an expert in the urine as a screening for disseminated disease, which we sometimes do when we have no real places to find the disease and the individual has suggestive symptoms. In total, by doing both of these things, we could have saved roughly $2,600 by not doing expert in sputum, and $13,000 by not doing expert in urine. Here I'm showing the crypto diagram. The first thing that I want to punctualize here is that right now in our centers we're using latex agglutination, and we do not have the lateral flow assays. The lateral flow assays are cheaper than the latex agglutination ones, so just by changing the assay we would be saving a lot of money because we're doing them in most of the individuals that present to care. Also, we tried to see if we could spare the use of or undergoing some lumbar punctures, but all of the individuals in which we could have spared this, we did not find any really. We thought maybe we have some individuals that were presenting that had neurological symptoms, but we could not do an actual cryptococcal antigen test, but we actually had the capacity to do on all of the individuals that presented with symptoms or low CD4 counts, so we could not have spared any of these procedures. And finally, the histodiagram. Here we assume that we could have saved money in the next scenarios. First one, just like in the crypto diagram, the urinary lateral flow assay is cheaper than the lifestyle we're doing right now, so that saves money. And then in people with negative TB-LAM that had both negative TB-LAM and negative urinary antigens for histo and CD4 counts of over 200, sometimes on this population, because we do not have any way to quickly say if they have or they do not have histo, we do bone marrow cultures. But if we could have these negative tests on the point of care, we could not do this test on this population. And also, sometimes we have individuals that present to care in critical clinical conditions in which we cannot really safely rule out histoplasmosis quickly. So if we could have from day one a negative result on a urinary antigen, we could not give them empiric treatment while we rule out diseases. This, by summing both of these numbers, we could save around 20,000 years. And finally, we have some other group of individuals in which we have them come in and they need to be hospitalized for their workup, but we don't really know that they have histo until a couple of weeks after they've been in the hospital. So if we could know that these individuals have histo from day one, we could also shorten their hospital stay and also save money. This amounted to more or less 23,000 USD. If you sum both of these up, it will be more or less 43,000, which is more than the savings that we could have from TB and crypto combined. Here I'm showing the group savings that I showed you in the diagrams. I just want to show that in total it's more or less 80,000 USD, and by user it would be more or less 242 USD. Just to put it in perspective, this is more or less what we would spend to treat 40 people with TB or 10 people with cryptococcal meningitis, which is a lot because that's what we had in a year. So that's the money that we use up in a year to treat all of these conditions. Or it's also more or less the payroll of 2 ID physicians. And here I'm also showing you guys the Kaplan-Meier curve for the time till opportunistic infection treatment initiation. Using the point of care package, we more or less calculated that we could have reduced the date of treatment initiation by 5, which is a lot. And it's really hard to know if this would actually have a clinical impact. But if everything goes according to plan and the bureaucracy allows it, I might be here next year to present you guys the prospective results and answer your questions. And to conclude, we think that implementation of these tests could definitely reduce the cost of care. They have a big potential for implementation, mostly in primary care, because we need to scale up these algorithms. And finally, histoplasmosis is definitely still a big elephant in the room. We're not doing enough about it, and it's definitely the biggest area for improvement, at least in Latin America. And just finally, because I'm overdue, I just want to say thank you to all of the members of the Perolio Study Group and all of my fellow residents and the people that wake up every day to make difference against HIV in our collapsing healthcare system in Mexico. Thank you.
next speaker is Dr. Mary Fraser. Mary Fraser is a public health master's at the University of North Carolina at Chapel Hill, United States, and her study is entitled Clinical Impact and Cost Effectiveness of Improvement Access to Cryptococcal Meningitis Diagnostics and Treatment in Malawi. Thank you, Mary.
Thank you. I'm not a doctor, but I appreciate the upgrade. It's a pleasure to be here on behalf of my co-authors. This is a summary slide of our main findings, but I have a lot of slides to get through, so I'm going to go ahead into the main presentation. Each year, cryptococcal meningitis causes between 13 to 20% of HIV-related deaths, and barriers to diagnosing and treating people with HIV with both symptomatic and asymptomatic cryptococcal meningitis in low-resource settings include CD4 testing, as well as the limited availability of lumbar puncture, or LP, in asymptomatic cryptococcal antigen-positive people with HIV, variable LP uptake, and variable but improving availability of antifungals, especially liposomal amphotericin B and flucytosine, or 5-FC. The objective of this analysis was to use simulation modeling to examine the clinical impact and cost-effectiveness of testing and treatment strategies to improve outcomes from cryptococcal meningitis in Malawi. We used the CPAC-I model to simulate adult people with HIV who were presenting or representing to care with both advanced HIV disease and a positive serum CRAG test. That was an LFA test. So the population includes 3 cohorts of serum CRAG positive people with HIV. 15% had symptomatic CM, 48% had asymptomatic CM, and 37% had asymptomatic cryptococcemia. And each of those cohorts have distinct probabilities of presenting with symptoms, progressing to more severe stages of disease, and death. I'm going to run through our estimates surrounding current care. The 3 cohorts that are included in the population on the left-hand side. And for people with symptomatic CM, in the model, most of them had access to an LP, and then the majority had access to single high-dose liposomal amphotericin B, 5-FC, and fluconazole. Those who did not were treated with liposomal amphotericin B and fluconazole, or 5-FC and fluconazole. Among asymptomatic individuals, we assume that they had no further testing, and that then they were treated with preemptive fluconazole unless they presented with symptoms. Based on these estimates, we evaluated 4 strategies: current care, and then current care plus an LP in asymptomatic CRAG-positive people with HIV, or a semi-quantitative CRAG, or CRAG-SQ, in asymptomatic CRAG-positive people with HIV. And then finally, further expanded access, 98% access to single-dose liposomal amphotericin B, 5-FC, and fluconazole. We also evaluated 2 combination strategies. I'm going to run through some model input parameters. At model initiation, the cohort was 51% female, with mean age of 37 years and CD4 count 27 cells per microliter. And given limited data on cryptococcal natural history, we estimated that over 6 months since initial infection without treatment but on ART, 78% of people with asymptomatic CM and 4% of people with asymptomatic cryptococcemia would have progressed to symptomatic CM. Mortality was 100% over a period of 3 months. Preemptive fluconazole efficacy was 69% in those with asymptomatic CM and 97% in those with asymptomatic cryptococcemia. And then CM treatment efficacy was 75% in the current care strategy and 82% in the 98% access strategy. An LP cost $43, a serum CRAG test cost $6, and preemptive fluconazole was $5 per month. And then CM treatment costs $730 in the current care strategy and slightly less, $720 in the 98% access strategy. And this is because of shorter hospitalizations and reduced drug costs. Model outcomes included 1-year survival, quality-adjusted life years, lifetime costs, and incremental cost-effectiveness ratios. And we considered ICERs less than $670 per quality to be cost-effective. These are our preliminary results. On the left-hand side are the 4 strategies that were non-dominated in the model. You can see that survival increases substantially as additional diagnostic and treatment components were added, with increases in undiscounted and discounted qualities as well. And then all the other strategies were dominated. So that means they were less effective and more costly or less cost-effective than the strategies on this slide. Moving to cost effectiveness, the strategy that included further expanded access to liposomal amphotericin B, 5-FC, and fluconazole was quite cost effective, with an ICER of $200 per quality compared to current care. And the strategy that included liposomal amphotericin B for CRAG positives with 98% access to an LP for asymptomatic CRAG positives and 98% access to liposomal amphotericin B, 5-FC, and fluconazole in all those diagnosed with CM. Was the preferred strategy at this threshold with an ICER of $640 per quality. So you can see these patterns a little bit more clearly in this cost effectiveness frontier. On the left, on the x-axis is incremental cost, and on the y-axis is incremental quality adjusted life years. The treatments are represented by colors and the diagnostics by shape. And then all of the non-dominated or the most efficient strategies are on the black dotted line. So moving up from the bottom left-hand corner with current care, you can see that all of the most efficient strategies included 98% access to single high-dose liposomal amphotericin B, 5-FC, and fluconazole. And that then expanding access to those diagnostics in asymptomatic CRAG-positive people with HIV results in substantial increases in life expectancy, even though it does come with some increase in cost as well. In sensitivity analyses, the preferred strategy generally always included further increasing access to liposomal amphotericin B, 5-FC, and fluconazole. And then we also found that use of CRAG-SQ could be preferred compared with LP in asymptomatic individuals if LP uptake were lower or LP cost higher, if CRAG-SQ specificity were higher, or if progression to CM occurred more quickly. Some limitations of this analysis include, we didn't include people with HIV with meningitis symptoms who didn't have a positive serum CRAG test, children or pregnant women. And the results could also be less generalizable in settings that have lower baseline access to liposomal amphotericin B and 5-FC than Malawi, although this is something that we're evaluating in scenario analysis in the model. In summary, continuing to expand access to both high-quality antifungals for all people with CM and for CM diagnostics in people with for asymptomatic CRAG-positive people with HIV would further reduce CM-related deaths and would be cost-effective in Malawi. I'd like to acknowledge my co-authors and our funders with special appreciation for our colleagues at EGPATH, the Malawi Ministry of Health, and the Bill and Melinda Gates Foundation. Thank you.
Thank you so much for your presentation. Our next speaker is Rotendo Weasley. He is at the Organization for Public Health Intervention and Development in Zimbabwe, and his talk will be entitled Link Between Poverty and HIV Viral Load Non-Suppression Among People Living with HIV. Thank you.
Thank you, Brenda, for the kind introduction. Good afternoon to you all. My name is Rutendo Wesley Mkodwa. I'm representing Organization for Public Health, Interventions and Development, OFID, from Zimbabwe. I'm going to present on the link between poverty and HIV viral load, non-suppression among people living with HIV. Our main question was to explore the relationship between poverty, social protection interventions, and HIV viral load among people living with HIV receiving ART in Zimbabwe. We had 3 major key findings. Number 1, HIV prevalence of poverty and food insecurity, association of poverty and food insecurity with HIV viral load, non-suppression. 3, limited access to food, cash transfers, or other social protection for people living with HIV. The importance of this study is that it addresses the complex interplay between poverty, social protection, and HIV outcomes. Background. Zimbabwe experiences a high burden of HIV and impoverishment, with HIV prevalence rate amongst adults which stood at 12.9 according to the Zimbabwe Population-Based HIV Impact Assessment 2020. Wealthy inequality is associated with the risk for HIV, may limit access to treatment. These disparities in terms of wealthy distribution can increase the likelihood of HIV infection. Households affected by HIV are particularly vulnerable to experience poverty. Why? Because of cost of accessing care. Social protection and HIV policy commitments. Social protection has become a key pillar of the 2025 UN AIDS goals and the United Nations Sustainable Development Goals, SDG. Why is this so? Because social protection intervention can protect against or reduce the impact of poverty and also can increase treatment adherence. According to the UN AIDS, at least 40% of people living with HIV should have social protection. Why? To reduce all financial burden in terms of illness. Method section. The study was conducted between January to August 2023. We used the mixed method study design. Quantitatively, because of the overlapping interest to understand social protection needs, we then layered a section of social protection within the ZNNP Plus monthly client satisfactory cross-sectional survey, where we included questions on multi-dimensional poverty. On multi-dimensional poverty, we measured poverty along 3 dimensions. We looked at healthy, we looked at the living standard, and education. We also included questions on unmet social needs, savings, and also we looked at the social demographic across 317 health facilities in 15 districts of Zimbabwe. Qualitatively, we administered semi-structured interviews to 30 eligible participants in 3 selected facilities in Chitumbiza. A total of 13,722 participants participated in 15 districts of Zimbabwe. In terms of the age distribution, the median age was 44, with interquartile range between 36 and 52. Under the sex component, female constituted the highest proportion, with 65.4 as compared to males. Multi-dimensional poverty is prevalent and associated with HIV virological non-suppression. As you can see to my extreme left, in terms of the multi-dimensional poverty, we measured poverty along 3 lines. We looked at healthy, where we looked at the nutrition and child mortality. Then under education, we looked at the years of schooling, as well as the school attendance. Then we also looked at the living standards. Nearly half of the participants living with HIV were multi-dimensionally poor. We also had an additional 25.3 were vulnerable to multi-dimensional poverty. To my extreme right, vulnerability to and experience of multi-dimensional poverty are associated with an increased risk of HIV virological non-suppression. Social protection coverage is scarce among people living with HIV, and gaps persist for the most vulnerable. Only 20% of people living with HIV that reported experiencing food insecurity or multi-dimensional poverty had ever received any form of social protection. According to the qualitative findings, social protection system is fragile and has not sustainably addressed the needs of the community. This was a quotation which was taken from a 40-year-old male, where he postulated that the cash transfer program would assist us when we get into debt. We were very careful when buying, would buy food that could last the whole month. Back then, we were able to send our children to school without any problems. That is what I can say with regards to the $48 that we received per month. These days, the challenges have gone back to where we were before the program. To conclude, there was high prevalence of poverty and food insecurity among people living with HIV. Like I have mentioned earlier on, 44% of respondents were multi-dimensionally poor, 43% lacked sufficient food, which was also associated with higher risk of viral load non-suppression. Number 2, there was limited reach and impact of social protection interventions. We have seen that only 20% of respondents had received any form of social protection interventions, despite high levels of poverty and food insecurity. The third key takeaway point, there is need for improved access and sustainability of social protection programs for people living with HIV. Qualitative findings highlight that accessibility to social protection that meets the needs of people living with HIV is lacking. Therefore, there is need for enhanced implementation. From what I've presented, I think it is time to integrate social protection in HIV prevention, care and treatment. I would like to acknowledge the following partners: Zimbabwe Ministry of Health and Child Care, TB Unit, Ministry of Public Service, Labor and Social Welfare, Zimbabwe National Network for People Living with HIV, President's Emergency Plan for AIDS Relief, PEPFAR, through USAID, to OFID Target Accelerate and Sustain Quality Care, the TASK program. Thank you.
Thank you so much, Rutendo. So, last but not least is Dr. Rafi Landowitz. Dr. Rafi Landowitz, he's a professor of medicine at the UCLA and chief of infectious diseases. He's a leader and expert in prevention, and I don't know if he's hearing us.
Yes, I am.
Perfect. Dr. Landowitz is going to present on behalf of the HPTN 083 a late-breaker study entitled Performance Characteristics of HIV RNA Screening with Long-Acting Injectables CAB-LA Pre-Exposure Prophylaxis in the Multi-Center Global HIV Prevention Trial Network. Thank you, Dr. Landowitz.
Thank you so much, Dr. Crabtree, for that very kind introduction. I'd like to thank the conference organizers for the opportunity to present these data on behalf of the HPTN 083 study team and for their generosity and flexibility in allowing me to present virtually at the last minute due to complications of travel. These are my disclosures. We have previously presented the primary blinded and unblinded results from HPTN 083, one of the two pivotal studies of long-acting...
Dr. Landowitz, please stop. We cannot see your slides.
Okay.
Just a second.
Okay, thank you. Thank you, and again, my apologies for not being there in person. We've previously presented the primary blinded and unblinded results from HPTN 083, one of the two pivotal studies of long-acting injectable cabotegravir for HIV pre-exposure prophylaxis, or PrEP. That study found superiority of CAB-LA compared to daily oral TDF-FTC for HIV PrEP in cisgender men and transgender women who have sex with men, leading to global regulatory approvals. HPTN 083 was also the first context in which LEVI was described, so-called long-acting early viral inhibition, the phenomenon in which long-acting PrEP agents delay detection of new HIV infection when algorithms consisting of antigen antibody or isolated antibody testing were used. We were able to describe that the use of RNA-based viral load testing, when performed retrospectively on stored specimens in a central laboratory, was able to identify these HIV infections earlier and often before the emergence of INSTI resistance. The ongoing open label extension, or OLE, of HPTN-083 aimed to prospectively evaluate site-performed RNA testing in addition to the previously implemented site-based testing algorithm at all visits for the early detection of HIV infection in the setting of CAB-LA use. The primary analysis includes visits and data from the participants' entry into the OLE, which varied across sites and regions until November 30th, 2023. Sites performed an FDA-cleared rapid antibody test, which was resulted prior to injection administration, and blood was obtained for laboratory-based antigen antibody testing and RNA testing, although those tests were not resulted until after the CAB-LA injection had been administered. The gold standard HIV status was adjudicated by an independent committee that reviewed both site-based prospective and central laboratory-based retrospective HIV testing. We calculated the positive predictive value and false positive rates of a single isolated RNA test and the sensitivity of RNA testing in combination with other testing assays. The overall study design is depicted here. The randomized blinded phase of the study required negative RNA within 14 days of study entry, as well as negative rapid tests and antigen antibody tests prior to, at, and subsequent to entry at all visits. Once the study was unblinded for superiority, we continued with the same testing algorithm during a one-year period awaiting open label extension implementation. The open label extension, in which 95% of participants still on study chose to receive open label CAB-LA for ongoing PrEP, augmented the previous site-based testing algorithm with RNA testing with a lower limit of quantification of 50 copies per milliliter or lower, which was performed at all study visits. The population represented in this analysis includes 2,619 participants contributing 26,528 visits at which RNA testing was performed over 3,892 person years. The median number of RNA test-containing visits per participant was 12, with a range of 1 to 22. You can see the breakdown of these parameters by original randomized study arm and by region. The bottom three rows of the table demonstrate the number of participants who selected CAB in the OLE and the number of visits those participants contributed that were within 6 months of CAB-LA injection, and the visits that did not have a CAB-LA injection within the past 6 months. This next slide depicts the iconography that I will use throughout the rest of this presentation. The top row represents adjudicated HIV status of the participant. Blue, HIV negative; red, HIV positive; black, those whose HIV status could not be determined based on the totality of the available data at the time of the data cut. The center row represents HIV testing results. Red and pink represent positive test results. Black and gray represent negative test results. The blood tube, labeled RNA, represents HIV RNA testing. The lateral flow appearing test represents an aggregate of rapid and laboratory-based antigen antibody tests. The bottom row denotes in blue events without a CAB-LA exposure in the last 6 months, and in yellow, events that do have exposure to CAB-LA within the last 6 months. I will leave the key to these icons in the footer of the slide as I proceed, so you can reference that. Of the 26,528 visits with an RNA test performed, there were 73 participants with at least one positive test result among the battery of 3 site-performed tests. Of these 73, 42 were adjudicated HIV negative. The HIV status of 2 participants could not be determined, and 29 were adjudicated as HIV positive. Of the 42 adjudicated HIV negative, which would be considered false positive results, 20 had a false positive antibody or antigen antibody test. 22 had an isolated false positive RNA test. Of the 29 that were adjudicated HIV positive, 5 were identified by an isolated RNA positive result. The remaining 24 were identified with multiple positive test results. You can see the breakdown of these positive cases with respect to proximity to CAB-LA injection with the color coding here. I am now going to report on test performance based on these 27 cases, the 22 false positive isolated RNA cases, and the 5 true positive isolated RNA cases. The overall positive predictive value of a single isolated positive RNA test was 18.5%, with 95% confidence intervals shown here. When considered by proximity to CAB-LA injection, the positive predictive value when CAB-LA had been administered in the past 6 months, the positive predictive value was 9.1%, with confidence intervals shown here, and 60% if there had not been CAB-LA administration in the last 6 months. False positive rates were overall low, including when parsed by timing relative to CAB-LA injection, reflecting the large number of testing events and the rarity of both true HIV acquisition events and false positive RNA results. Interestingly, of the 22 false positive test results among the 26,528 testing events, these results were disproportionately concentrated among 9 of the 43 sites. In fact, half of the 22 false positive RNA testing events were from one single site. The distribution of the 9 sites at which false positive results were concentrated represented a range of geographies. Exhaustive QA and QC evaluations of the 9 sites' laboratory processes and performance did not identify a source of these false positive results. The sensitivity of RNA testing in combination with other test results is shown here and overall is outstanding. In an attempt to identify a discriminatory threshold for true versus false positive RNA testing results, we have parsed viral load results by proximity to CAB-LA exposure in yellow and blue, as well as true versus false positives. The medians and ranges for each group are shown here. Although imperfect, 200 copies per milliliter as an isolated single RNA value, which was used in HPTN 083 and 084 as a breakpoint for determining confirmation of HIV infection for study teams, seems a reasonable breakpoint for clinical implementation. In the data observed today, to date, all occurrences of a single isolated RNA that was detected but below the limit of quantification were false positive results. Importantly, and particularly applicable to the context in which RNA testing is currently being implemented as part of CAB-LA prep monitoring, an isolated positive RNA can be confirmed with 100% certainty to be a false positive result if repeat RNA and antigen antibody testing is negative. Similarly, a repeat test algorithm reveals a second isolated positive RNA test or positive RNA test in combination with other positive test results as having 100% positive predictive value for true infection. Understanding that these isolated positive RNA tests can be disambiguated by repeat testing, there are still significant clinical consequences to a first positive RNA that is inaccurate. In HPTN 083, 7 of the 22 false positive test results experienced a delay in subsequent CAB administration, including delays in injection, discontinuations, and delays in oral dosing. Happily, none of these participants who experienced a delay because of false positive isolated RNA test results has shown evidence of HIV acquisition to date. We conclude from this preliminary analysis that a single isolated positive RNA test done at study sites performed poorly for detecting HIV infection in the setting of CAB-LA prep. RNA testing performed better absent CAB-LA exposures in the past 6 months in this population, and a repeat RNA test was able to discriminate true from false positive results in all cases, particularly important in contexts where this is currently being implemented. Although both true and false positive test results were infrequent, most isolated positive RNA test results were false positives, and 1/3 had delays in prep continuation. Guidelines for HIV testing in the context of CAB-LA prep should consider these performance characteristics. Thank you to our sponsors, our sites, our participants, and to you all for your attention.